There are two types of catheter occlusion. It can be partial occlusion or complete occlusion. In case of partial occlusion, there is sluggish flow or lack of brisk or free-flowing blood return. In this case, blood can be infused but cannot be withdrawn. To rule out a partial occlusion, it is advisable to assure patency prior to administering medications. In case of complete occlusion, there is inability to infuse or aspirate blood from catheter. There is no blood in return. Assessing catheter function is important. It is important to assess catheter patency prior to every infusion to avoid complications that may arise from attempts to infuse into occluded catheter. Assessing patency of catheter is important to rule out problems like lack of blood return in catheter, sluggish blood return in catheter, increase in resistance when flushing catheter, and inability to withdraw fluids even if you are able to infuse in catheter. If any of the above problems exist within the catheter, then the catheter is occluded. Standard of practice. The nurse should aspirate the catheter for blood return as a component of assessing catheter function prior to administration of medications and solutions. What will happen if occlusion in catheter is not removed? If the occlusion in catheter is not removed, it may lead to infection associated with thrombotic occlusion, occlusion in vein caused by fibrin buildup, infiltration or extravasation caused by backflow, interruption of therapy, and unnecessary catheter replacement. Unnecessary catheter replacement shall be avoided. Whenever possible, salvage of an occluded catheter is always preferable. Replacement of catheter can delay therapy of the patient. Salvage of catheter also preserves number of sites available for future access. Unnecessary catheter replacement can lead to potential difficulties like disruption of therapy, increased patient discomfort, increased complications, and increased cost of care. When a catheter becomes dysfunctional, the main goal is to restore function in a timely and cost-effective manner with minimal risk to the patient. Currently, there are following modalities for clearing catheter occlusion: heparin, saline flush, streptokinase, TPA, and catheter replacement. There are shortcomings in current techniques of clearing catheter occlusion. Heparin can be used to clear catheter occlusion, but heparin is an anticoagulant, hence, after forming thrombotic occlusion, role of heparin is limited. Streptokinase is also used for clearing the occlusion in catheter, but streptokinase causes certain allergic and antigenic reactions. TPAs are used for clearing catheter occlusion, but TPAs are not cost-effective. There is a dire need of a thrombolytic agent, which does not cause allergic and antigenic reactions, which is also cost-effective and meets international standards for catheter clearance. Only a low-dose urokinase can meet these requirements, and that low-dose urokinase is Eufrag 5K. Eufrag 5K is 5,000 units of urokinase. To overcome these limitations with existing modalities, launching low-dose urokinase is a perfect combination of safety and efficacy. The best occlusion manager. Now let us see how Eufrag 5K acts inside catheter. Eufrag 5K remains in contact with the lumen of the catheter. It binds with the fibrin in thrombus, hence converting plasminogen into plasmin, thereby causing dissolution of clots. The remaining debris of clot is then aspirated when blood aspiration is done to ensure that the catheter function is restored. 5,000 units of urokinase of Eufrag limits the dose of Eufrag in catheter, and it does not enter systemic circulation. Now let us see how to use Eufrag 5K. There is a 3-step formula to use UFrag 5K. Step 1.
Reconstitution.
A septic technique shall be followed when diluting lyophilized powder of UFrag 5000. Withdraw 2 to 8 milliliters of 0.9% normal saline aseptically into syringe. Direct the stream into powder and gently swirl the vial until content is dissolved. Do not shake the vial. Step 2. Installation and administration. Withdraw the reconstituted solution from the vial and scrub the hub. Apply vigorous friction to the hub for 15 to 30 seconds and insert the syringe into the hub. Create a negative pressure by pulling plunger of syringe back and holding for a few seconds. This will help UFrag 5K to mix with the fluid in the catheter and instill the UFrag 5K into occluded catheter. Step 3. Assessment and aspiration. Dwell for 30 minutes. After 30 minutes, assess the catheter function by attempting to aspirate blood. If the aspiration is successful, then catheter is functional. Or, if the aspiration is not successful, assess catheter function again after 60, 90, and 120 minutes by attempting to aspirate blood. If catheter is still occluded, then second dose of UFrag 5K is to be instilled, and as discussed, 3 steps shall be repeated. Aspirate 4 to 5 milliliters of blood to remove UFrag 5K and residual clot. This 3-step formula of UFrag 5K thrombolyzes the clot in catheter, and catheter is recanalized.